Well, welcome to this pharmacology drug class review on the category of bronchodilators with a specific focus on the long-acting muscarinic antagonists. These drugs have been well-known, well-established options mainly for patients with COPD and a certain subgroup of patients with asthma. Now, Tiotropium, it's been around for a long time and still widely used. This class, the long-acting agents, has grown a lot over time, highlighting their value in COPD. Hey guys, I'm Dr. Busti. Thanks so much for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the decisions that we make all the time. That includes pharmacology and the drugs that we use every day. When we understand that why, the how becomes easier, and that mechanism starts to predict the therapeutic effects, side effects, monitoring parameters, counseling points that we use all the time, or we should use all the time. Now, with all my drug class reviews, I cover core content, things you got to memorize sometimes, especially if this is newer information for you. We have the agents, indications, common uses, the net benefit, why pick this drug class over others, the pharmacology mechanism, some application of pharmacokinetics dynamics, and then we move into that clinical application, the pearls that make it really come alive. So let's start off talking about the agents. As I mentioned, there's quite a number of options here. You don't see Tiotropium here because this is the long-acting muscarinic antagonist, and many of them are in formulations that are dry powder inhalers. We do have a few that are available in a soft mist like Tiotropium, or sometimes people use the word Tiotropium. It's a soft mist inhaler, but also a dry powder inhaler. Revefenacin is a nebulized formulation. So the reason that matters is because, again, you have to recognize the name of the drug with its dosage formulations, which then influence not only the method of delivery to the site of action, but some of the counseling points that we make. Okay, now we're going to move on to the indications and uses of this drug class, and it's pretty straightforward. Again, I said asthma, and it's with selective agents, and really, quite honestly, certain severities when patients haven't responded to other medications that you should be on, like inhaled steroids, long-acting beta agonists, those kind of medicines, in the asthma bucket. And the COPD bucket, this is definitely the mainstay of where we predominantly use these drugs. Now, I want to take a moment and talk a little bit about the overall two disease states that we've been mentioning, asthma versus COPD, and the general approach to management, and some of the reasons why we target certain drugs more in one disease over another. Again, these tables are available at thisiswhy.health for you for free. The link associated with this episode is in the description on YouTube, or if you're on our podcast channels at Spotify and Apple, they're available there as well for you to be able to go to the page to get this information for studying, sharing with your friends and colleagues. If you're a preceptor or faculty, feel free to use it. So asthma versus COPD, the cell types are different. Remember, asthma is predominantly eosinophils and COPD is neutrophils. So when we have this more allergic component with the asthma side, right, then that's where they respond well to bronchodilators. They respond a little bit better to, obviously, inhaled corticosteroids. On the COPD side, those neutrophils cause a significant amount of inflammation, hypersecretion of mucus, but eventually left untreated and regulated leads to remodeling of the airway. So you don't get a good bronchodilator response. But one of the reasons why antimuscarinic drugs work better in this patient population has a lot to do with that mucus production and the mechanisms that sometimes we can dry those up and reduce some of that and maximize the airflow going through. That makes people feel better, okay? Now, with that, we need to recognize that patients with COPD many times will also overlap and have symptoms that is similar to asthma, and that's called ACOS, asthma COPD overlap syndrome. So while we may be using antimuscarinic drugs or anticholinergic medications that are predominantly better in COPD, that doesn't mean we won't add on inhaled steroids or use beta agonists to maximize the overall effect. In fact, what you're going to see here later on in the lecture, I'm going to show you formulations where there are 3 drug regimens where patients are on long-acting beta agonists with a long-acting muscarinic antagonist with an inhaled corticosteroid. Again, some of these patients are going to be the reason we do that. And if we can maximize adherence, compliance, we improve their symptoms, we reduce their need to utilize the healthcare system, and we keep them functional and enjoying their quality of life. So that's some of the important perspective that I wanted you to get as it relates to this. Now, we're going to move into the net benefit of this drug class, and it's important. This is huge. Like, again, the number of agents and the growth of this class, it correlates a little bit to the value, obviously, that it has in the evidence. So long-acting muscarinic antagonists improve lung function and COPD symptoms. That also includes the risk of exacerbation. And so that's really important because, again, it keeps people out of the clinic. It keeps people out of the hospital and emergency department where they need then acute management type therapy. Now, again, in the patient with severe uncontrolled asthma, drugs like tiotropium can be helpful in those patient populations. Again, probably because of that, some of that degree of overlap syndrome that the patients are experiencing. All right, now we're going to pivot over to the pharmacology, and as I've done, depending on if you've watched other lectures in this series where I cover the long-acting beta agonists, the short-acting beta agonists, the short-acting muscarinic antagonists, you need to have your mind wrapped around the anatomy, and so I would recommend that you make sure you get it and you understand it's solid. Don't ignore this stuff, because if you don't get the drug to the site of action, it doesn't work and exert its effect. And in COPD, this becomes very relevant where the mucus production is occurring. So this image shows you basically the basic anatomy. You have to get the drugs. We're administering these orally through inhalation, and it's a topical administration. So it has to deposit on the airways. Well, where is it depositing? Not up here. Not up here. We need to get it way down here in these real small distal airways called the bronchioles. When you look at the other airways all the way up, they've got these cartilaginous rings that hold them open. But the bronchial is the area where that regulates predominantly that airflow. It's also where most of the symptoms that people have get manifested if there's a constriction or spasm in that area. And so in our normal anatomy, when you zoom in at that distal area, the bronchial, you see these bands of tissue. Those are smooth muscle tissue that contract and dilate, that regulate that airflow. Okay? It's regulating the flow of air down to the alveoli. Okay? So let's zoom in on that. You can see that the alveoli have a lot of blood vessels. We have arterial blood coming in, we have venous blood coming, also going in and out, and that's allowing for oxygenation, ventilation. Oxygenation is the delivery of oxygen into the alveoli to diffuse into the blood that's deoxygenated. And then it's also facilitating the removal of CO2, which is a byproduct of metabolism, to be eliminated. That's called ventilation. So if you occlude or collapse the airway, then you're going to trap air inside this alveoli that's not going to be able to maximize the gas exchange in either direction for oxygenation or ventilation. Okay? And so what can impact that? Well, there's a lot of things. One is swelling and edema. So in asthma, that's what we see. We see the smooth muscle tissue getting edematous, irritated, it spasms. They respond much better to bronchodilators, specifically beta agonists, right? And then they make some mucus, especially in more severe cases. Now the COPD patient, though, remember, goes through transitions, a phased growth between chronic bronchitis, which is that wet, productive cough, then eventually the remodeling sets in, and then they have weak airways, and that remodeling of the damaged membranes causes collapse of the alveoli, changes the surface area of the alveoli for a gas exchange, and that's why patients start to having problems with gas exchange, because the airway falls on itself, obstructs, so it's an obstructive airway disease. It traps the air because of these weak walls that have been remodeled, and we've reduced the surface area necessary for that gas exchange to occur. But I've got to get the drugs down here. I've got to get down there. And you see in bronchitis, there's a lot of secretions and mucus being made. So antimuscarinic drugs can reduce some of that as well as bronchodilate. Well, how does it bronchodilate? So once it lands there in that smooth muscle, what is it doing to really relax that smooth muscle to allow more dilation of the bronchiole to allow airflow through that area of the airway? And so you see I've listed here the number of different drugs that bind to that receptor. It's predominantly, when we think of the receptors in the muscarinic receptors, it's the M3. Now some of our drugs like Tiotropium are less selective. Some drugs are more selective at different ratios. You can read about kind of that stuff and splitting hairs, but those are some of the nuances that give us a little bit of a difference between one drug over another. But you're binding to these muscarinic receptors, and you're not activating them, you're antagonizing them. And so this is a long-acting muscarinic antagonist, whereas remember drugs like albuterol is a short-acting beta-2 agonist. It's turning on the beta-2 receptor. And so this negative sign is saying, hey, I'm going to inhibit these muscarinic receptors, and when I do that, I affect the intracellular physiologic and biology that's going on. We reduce secondary messengers, things like IP3 and DAG, that reduce the overall net cytosolic calcium concentrations. Well, why does that matter? Well, it matters because actin and myosin need calcium intracellularly in order for them to bind and hold together and contract. So if I reduce that, take away the actin and myosin interaction, I result in the net effect is bronchodilation. But I also reduce bronchial secretions. So that helps me to maximize that airway and airflow, which is probably why they work a little bit better in COPD patients than in asthmatics, right? Unless the asthmatic patient is more severe, uncontrolled, and or in that ACOS group. That's why I spent time talking about it, okay? Because it's going to be hard sometimes for you to fit every patient in one little particular bucket. It's not always the case. So as it relates to pharmacokinetics dynamics, we think about onset. Now these are long-acting drugs. We don't care about, we're not trying to get some acute onset, even though that can be as early as 5 to 15 minutes with glycopyrrolate and drugs like that. We should not try to utilize that feature, pharmacokinetic dynamic parameter, to suggest that it would be helpful in acute. These are preventative medicines. We're not using them for acute exacerbation, right? If you need something for acute exacerbation, then you use the short-acting drug Tiotropium, okay? And I have another lecture that covers that as well, and you'll be using like albuterol, levalbuterol, those kind of drugs in the acute flares of COPD or asthma. Now, part of its structure is relevant because we don't want these drugs. We absorb some systemically. We administer them orally, inhalationally for a topical administration to work on the cells in the area that we need them to work, which is the airway. But we also want to reduce the systemic absorption because we don't want systemic side effects. Well, part of the chemical structure of seeing this is that it is a quaternary ammonium, which is charged. And that charge makes it less lipophilic or more hydrophilic. Well, the less lipid lovering something is, the less likely it's going to penetrate through the blood-brain barrier. And so that's why some of this can be helpful and limit some of the anticholinergic or muscarinic side effects of these medications, but they're not completely, obviously, benign. Okay, now we're going to pivot over to the clinical knowledge, and this is where I'm going to dive into and make sure that we consider the delivery of the medication. Now, we have a number of dosage formulations and routes that we can administer these medications for patients. Most of them are usually, again, a dry powder, and this is only one example of a dry powder inhaler up here. There are different shapes, styles, depending on the drug you're using. I just wanted you to recognize that it's not a pressurized device like a typical meter dose inhaler, okay? We don't need a spacer for it, okay? You have to activate this, which is usually perforating something or putting a capsule in and allowing the powder to come out. But the reason this matters is that the inhalation technique, the inspiratory flow rate for dry powder inhaler devices is different than those that are propellant mediated, or even the way we would administer a nebulized formulation, which we have in this group, okay? Just like we have a nebulized inhaled corticosteroid that we can administer. So when you understand the name of the drug, the brand names, and then you look at the way their methods of delivery, it becomes important for our counseling, because the inspiratory flow rate has to be greater for a dry powder inhaler to get it up and out of that device. There's no propellant like with these agents, okay? So that's why that matters. Now, when you think about the traditional steps of how do we get the drug from the device down into that bronchial of the airway, there is a technique. And the traditional teaching of techniques is centered traditionally around, most things I see and hear, material is centered around propellant or pressurized devices, metered dose inhalers. But the dry powder inhaler requires a different inspiratory process, and you don't shake it, right? So in this step 2 here, where you would normally make sure that the canister is pressurized, we're not doing that with dry powder inhalers. We're not doing that with nebulizers, okay? You just get yourself ready. Well, that means you go to step 3, you blow out the air, and then you start to inhale. Now, if you're pulling it out of a device, the inspiratory flow rate needs to be more forceful and continuous to get it down to the airway. Or if you're doing nebulizer, it's a slow, continuous deep inhalation. But then you hold your breath for 10 seconds so that it can, as it's aerosolized, floating around in the air that you breathe in, it deposits on the tissue and exerts itself at the site of action. Okay? It's not going to do me any good in the back of the oral pharynx. So the wrong technique applied to the dosage form that was being used can result in inadequate efficacy. I cannot stress that enough. Okay? And this is where you place it in your mouth. Now, this would be obviously relevant for a pressurized device. So if you use the soft mist like tiotropium, you have to use the device correctly even though it's not a dry powder, okay? And you've got to get that drug down in there. And so if you are on the nebulized formulation, you still need to be having that deep inhalation, hold your breath, blow it out, right? But just because something's being administered this way doesn't make it more effective. It still requires the utilization of tools and methods to get the drug down there. And so in drugs that are available in a propellant formulation, that's why we use the spacer to facilitate that. But when we blow out, it's a slow, continuous kind of blowing out after we've allowed for that deposition. Inspiratory floats without any pause means you're blowing out some of the drug with it, okay? Now, patients who are at higher risk for exacerbation, right? Tiotropium maybe, or tiotropium, depending on how you want to say it, is preferred as most of the evidence supports its use. It's been around longest, right? The other agents are really good as well, okay? But again, most of the data historically supports that. Long-term benefit of COPD, again, remember we're trying to maximize that airflow and reduce their symptoms and the frequency of their COPD exacerbations. We're also trying to avoid worsening cardiovascular problems. When patients aren't getting adequate oxygenation or ventilation, that can affect the pulmonary pressures, but it also affects the oxygenation and delivery to our heart, which can be, obviously problematic. When we use these drugs in asthma, remember it's a selected group of people, okay? So it's reserved for that uncontrolled, severe asthmatic who have already been put on things like inhaled corticosteroids, maybe a long-acting beta agonist, biologic therapy or some other thing, and they just cannot get to goal, or they're requiring oral steroids. That's not typically one of the things we want to do long-term. And so they may be that patient with that overlap syndrome and would benefit from this, okay? And so there are formulations that have been shown to help us in that situation, especially in patients with asthma. And again, tiotropium tends to be more commonly used. Obviously, patients with COPD are at greater risk for pulmonary infections, that many times viral, but also bacterial, atypical infections, those kind of things. And when you compare long-acting muscarinic antagonists to inhaled corticosteroids, there is a slightly lowering risk of secondary pneumonia and also similar reduction in exacerbation rates. Again, highlighting their value and their growth as a class. Moving on to dosing, there's really no dose titrations like, it's pretty straightforward, commercial dosage formulations. These are again used for prevention, maintenance. We're not using these in the acute scenario. Some formulations do have capsules, and we just need to make sure that we counsel patients that the capsule goes into the device, not something that they swallow. The reason I bring that up is that there are medications that can be used, phosphatase inhibitor, type 4 inhibitors, that are administered by mouth, which is kind of sometimes counterintuitive with the other drugs that we use. But remember, we have drugs like terbutaline, right, that are administered different ways than traditional inhalation. So just keep in mind when you have these that we have to educate patients on those, that they're not to take them by mouth. As I mentioned at the beginning, a lot of these drugs are used in combination with other agents. So we have drugs that are a combination with long-acting beta agonists with a long-acting muscarinic antagonist. Again, these are all used for predominantly COPD mainly. Again, few rare scenarios with the asthma. We have the combinations because they should be on what? An inhaled steroid. If you're giving these drugs, they better already be on a steroid because you're not treating the underlying problem in that situation, and that's inappropriate. And so that's where the 3-drug regimen is so helpful for adherence and compliance. Now, some side effects. Fairly well tolerated, glaucoma is really more of a relevant risk in the nebulized formulation. Why? Because again, when you look at that face mask going on, it's spewing out into the air around your face. So that doesn't make it better. It means you're medicating the air and the things around you. But you can also medicate your eyes because of that physical contact. And so that can worsen pressures in patients with uncontrolled glaucoma, which could obviously lead to eventually blindness if left untreated, is a concern for these certain patients. Urinary retention, again, those are the anticholinergic properties, constipation, dry mouth, those kind of things. Again, it has to do with the amount of systemic absorption. So if you deliver it correctly and it gets to the site of action and you're not swallowing it as much because you use the wrong technique, that will minimize some of that. And then monitoring parameters. Yes, our SaO2s are going to be helpful, especially in our COPD patients. Again, that's reflective of our oxygenation. It does not reflect ventilation, right? Sometimes we have to have a CO2 detector or measure it by VBG, ABG if we're really concerned of hypercapnia or retention of CO2. Respiratory rate. Remember, how fast are they breathing? How hard is it getting difficult? Their airways collapsing. You'll see them do pursed lip breathing mechanisms to try to keep the airways open and create positive and expiratory pressure. Checking their lung function. Is it progressing, and why if so? Right? Do we see improvements in the FEV1, FVC? These are the parameters that we're predominantly looking at, as well as their symptoms and the number of exacerbations. And when you look at the overall kind of management tools of COPD in particular, one of the tools that we use to kind of categorize the severity of patients is the amount of exacerbations and utilization of the healthcare system to guide us in that. Because that's an indicator of whether they're doing well, isn't it? Okay, guys, so this represents the long-acting muscarinic antagonist. It does not include Tiotropium completely. I mentioned it a few points in context, but I do a review on that, and that's if you need to finish up and understand all the bronchodilators. We have other topics, long-acting beta agonists, short-acting beta agonists. But these drugs are being used predominantly for COPD and then a subset of asthmatic patients, maybe even selective more to the agents. Remember, they're working on that muscarinic receptor. Predominantly, you want them to work on the M3 receptor. Tiotropium is a little bit less specific. And that dilates, but also dries up some of those secretions. Okay, remember, we can get some systemic absorption. It can also get in your eyes with nebulizer treatments, especially that Tiotropium, right? And urinary retention, those are risks. But these drugs work great overall And that's again why that class has grown. That's why you see all the dosage formulations. And I hope that me putting it in the context of that, especially as it relates to asthma versus COPD and the management, so because you need to learn both. You need to know why you're learning this stuff and where it's going. That's the why, okay? And that's what this show's about, teaching you the why because it makes the how easier. Now guys, if you haven't joined us on my YouTube channel, please give consideration to being a member, subscribing. You can also be a member at thisiswhy.health for free things. We have newsletters and blogs, things that we try to communicate things, where you teach, learn something in nuggets, new content. So on YouTube, ring that bell, give us a like. We really appreciate when you take the moment to give us a like because it helps us and it helps other people to find information when they need it. And that's what this is about. We all helping each other out. I'm Dr. Busti, and thanks so much for joining. Never stop learning the why because it makes the how easier and our patients benefit from it. Take care.